right, good morning, everyone. Good morning, everyone. Thank you. I know we have a few people are here from California, other places, so it's very early. We welcome them being here. So on behalf of the U.S. Department of Health and Human Services, welcome to the inaugural Sickle Cell Disease Summit. We're so excited that you are all here. This has been a labor of love for a number of my colleagues, and we are so proud of the prioritization of this issue in this administration. Is this anyone's first time here in our nation's capital? No. hand went down really quick. Anyone? Oh, we have a few. Welcome to beautiful, sunny D.C. It doesn't get any better than this. In our nation's most beautiful building, routinely called the ugliest. So my name is Lizzie. I use she, her pronouns, and I am the Acting Deputy Director of Policy and Legislation for the Assistant Secretary for Health. But more importantly, for your purposes, I am the MC for today, and I am just incredibly honored to be here with you. It truly is a true honor to be in community with everyone that's here today. There are hundreds in this room coming from across the country, some from outside of the country. But we also have hundreds more who are joining us online, streaming in from around the world. You all are welcome here, and we are thrilled and very fortunate that you gave us your grace and your expertise today. So this historic summit is taking place during National Sickle Cell Awareness Month, which is a time for us to celebrate this phenomenal community, including your persistence and resilience in terms of your own health advocacy, but also for the movement. We, too, use this time to reflect on all of the milestones that have been achieved, especially as of late, in terms of research, advocacy, and treatment to improve care across the lifespan. Today represents a celebration and dialogue, yes, but it is also a launching pad, right? It's our opportunity for all of us in this space to tap into pockets of bold, innovative, community-led progress, make and form new and lasting connections we bring back with us to our communities, and to increase awareness around the country about the impact of sickle cell disease on warriors first and foremost, but also their families, their providers, their allies, and their advocates. So, what's in store for us today? Well, we are going to hear from a diverse array of leaders in this space, including Secretary Javier Becerra, a stalwart champion for the sickle cell community. Stay tuned as well for a very special fireside chat with the incredible actress and advocate Umi Musaku, who is so generously sharing her personal reproductive health journey as a mother who carries sickle cell trait. We are also proud to be recognizing the trailblazing Dr. Clarice Reed, the longest tenured sickle cell disease administrator in the history of the National Institutes of Health. Where is Dr. Reed? She's somewhere. She's grabbing some coffee. Later today, Dr. Reed will be receiving the Assistant Secretary for Health's Exceptional Service Medallion Award, which is the highest civilian honor and award from the United States Public Health Service. So a few housekeeping items before we get to the real good stuff. First up, HHS staff, Health and Human Services, acronyms. Call me out if I use acronyms. HHS staff, if you're in the room, raise your hand. So take a look at folks in the room who are raising their hand right now. It's important, very important to us that this event feel safe, welcoming, and accessible at all times for you. So if at any point you need help, flag down an HHS staff person. They can help with finding a restroom. They can help with finding medical care if needed, accessing heating pads, water, and so forth. Just flag them down, and they are there to help. Next, in order of importance, bathrooms. Bathrooms, easy to find. Straight out and left. There are signs that will take you right there. If you need help finding them, let us know. We also have gender-neutral bathrooms now behind the stage. Single-stall bathrooms, but they are accessible to you. Food. I haven't been to a government event with food. This is very exciting. The way you can get to the food is straight out to the right. It's in our beautiful East Wing, which has a gorgeous view of the Capitol and the Botanic Gardens. There will be pastries and coffee there this morning. And at lunchtime, we have box lunches for everybody, which were generously donated and we're incredibly grateful for. Today's summit is also being live streamed, and the recording will be posted to HHS.gov/live, and we are hoping to share that widely with the field and hopefully make some snippets of the incredible panels we have today. You can also join our online conversation using social media, share your reactions and messages with the field throughout the summit today. We have a photo wall. David, where is the photo wall that people can find? David, where's the photo wall? Right up here on the left, we have a great photo wall. You can take photos and tag them with our hashtag. And yes, this is government, so it's a long hashtag. We did not workshop this. It is hashtag HHS Sickle Cell Disease Summit. HHS Sickle Cell Disease Summit. If you need help remembering that, just flag one of us down. But we would love to repost you, reshare what you're sharing as well. And last but not least, something very exciting is our raffle. We are doing a really fun raffle of some highly prized items today, including a signed version of the insignia, our concept poster for today, signed by our speakers. We are also raffling off some one-of-a-kind artwork created live today in this room. And with that, I would love to introduce to you Simone Vaughn. Miss Simone, can you wave? Thank you, Simone. Simone is here with her mother, Nakia, and her father, Shimon. Simone is a 12-year-old warrior and a phenomenal artist. And throughout the summit, she will be creating artistic renderings reflecting the energy, tone, words, movement of today. And graciously, she has agreed to let us kind of raffle off her artwork at the end of today. So the way to enter into our raffles, they're all free, of course, is during lunch, we'll be going around and asking if you're interested, and you can put your name in a hat. And then you'll have to wait till the end of the event to find out who won. So that feels like plenty of housekeeping, so let's move on to the actual good stuff. It is now my great pleasure to introduce someone whose leadership has been instrumental in advancing collaboration between the government and external partners on critical health issues such as sickle cell disease. Eduardo Cisneros serves as the Principal Deputy Director of Intergovernmental and External Affairs at the U.S. Department of Health and Human Services. He first joined the Biden-Harris administration as Intergovernmental Affairs Director for the White House Office of the COVID-19 response. Additionally, Eduardo will also introduce our opening keynote of the morning, so please join me in welcoming him to the stage.
Hey, good morning, everyone. Welcome to HHS. It is a pleasure to be here with you all. Can we just thank Leslie and Captain Wong and others and on the staff for, again, organizing this first ever Sickle Cell Disease Summit. That's a big deal because, as Lizzie alluded to, we're in the federal government, so we know these things take a lot of effort just to put something on like this. So thank you for being here. It is an absolute pleasure to see the room packed. And again, this is the inaugural one, so we hope to continue this year after year as we continue to focus on sickle cell disease and treatments and advancements in that space. It is an absolute pleasure to welcome all attendees, including some warriors, advocates, healthcare professionals, and researchers. Today and this month is about recognizing Sickle Cell Disease Awareness Month, but it's also important to discuss that while we've made a lot of progress, there's much more to do, and it's important to recommit to finding a cure for SCD and to supporting those who suffer from the disease and addressing healthcare disparities that exist in communities, in too many communities across our country. We all know too well that while SCD impacts people across the country, it disproportionately impacts Black and Latino communities in particular. But there's hope in our healthcare professionals, there's hope in our researchers, and there's hope in our science that we will continue to work to find transformative treatments and other cures for the disease. So again, this room gives me hope. We have a great program today. You'll be hearing from our fearless leader here at the department, Secretary Becerra, a little bit later. We have some great speakers joining us, including an actor that I'm personally a fan of, and other special guests. And so you'll hear from them as well. And then, of course, members of Congress and other distinguished guests. But with that, it is and actually I should repeat, as Lizzie said, it's the federal government and it's long, but please share on social media your experience here today. Hashtag HHS Sickle Cell Disease Summit. Again, not the shortest one, but HHS Sickle Cell Disease Summit. Please post, share, tweet, X, all that good stuff. Thank you for partaking in that as well. But again, my distinct pleasure to introduce this morning's keynote speaker, Dr. Donnell Ivey. He's Vice Chief Medical Officer for the Sickle Cell Disease Association of America. Dr. Ivey is a sickle cell warrior and physician who uses his personal and professional experiences to improve care for individuals with healthcare condition, including SCD. By working collaboratively to strengthen the public health infrastructure, he's made a lot of great gains in this space. Currently, Dr. Ivey serves as the Vice Chief Medical Officer of the Sickle Cell Disease Association of America, SCDAA, as I mentioned. But before that, he also worked at the Association of Black Cardiologists and also worked here with us at the very own HHS HRSA, or Health Resources and Services Administration. So it is a great pleasure to have him here. At HRSA, he served as the program director for the hemoglobinopathies program, including SCD treatment demonstration program and the SCD newborn screening program. So a great leader in this space. Dr. Ivey began his federal career at the National Health, Lung, and Blood Institute, where he helped develop some of the very critical SCD clinical treatment guidelines that we have today. So please join me in welcoming Dr. Ivey, our keynote speaker.
Thank you so much. Good morning, everyone. And thank you so much for coming out here today. I want to thank the HHS staff and Secretary Becerra for putting this event on today. It's very important that we educate the community about sickle cell disease. Now, when David asked me to do this, he said I can do it as a TED Talk, so I'm going to walk around the stage instead of just standing at the podium. As it was mentioned, I'm the Vice Chief Medical Officer for the Sickle Cell Disease Association of America. But more importantly, I'm a warrior living with sickle cell disease, hemoglobin SS. Now, as my favorite writer and poet said, life for me ain't been no crystal stairs. Living with sickle cell disease has been a significant challenge in my life. As a young child, I would often have crises that would put me in the hospital for days, weeks, and months, during which time I would be away from family and friends and also interrupting my education. It was during high school, so as a child, I always wanted to go into the Air Force and be a pilot. That was my childhood dream. But it was in high school that I learned that my dream would never be fulfilled. Because I had sickle cell disease, I wasn't able to go into the Air Force, much less become a pilot. So as Langston Hughes asked, what happens to a dream deferred? I could have gotten angry and exploded with anger and frustration. I could have sagged from the load of sickle cell disease. I could have done any number of things, many of which would not have been productive. But it was during that time that I declared war on sickle cell disease. I said that since sickle cell disease had destroyed my life, I'm going to dedicate my life to destroying sickle cell disease. And I was thank you. And I was fortunate enough to go to college at North Carolina State University, being the first person in my family to attend a 4-year university. Now, college with sickle cell disease was a huge challenge. I continued to have frequent crises that would require me to miss weeks to months from classes. And if you think about taking biochemistry and genetics and physics and all those other courses you have to take, It was an extreme challenge. I was fortunate that I found doctors and nurses at the North Carolina State Infirmary that agreed to work with me. Although they weren't sickle cell experts and they admitted to me they didn't know much about sickle cell disease, they said they would do what they can to treat me when I had pain crises. They would give me IV fluids and pain medicines, but often they didn't have the expertise or the resources to treat me on NC State campus, so I would often have to go to the hospital in Raleigh. That went on for about 3 years. Of course, dealing with sickle cell disease was a challenge. I would often miss weeks of classes. I didn't withdraw, though, because I said, hey, one, college is very expensive. And so if I started withdrawing, I would go deeper into debt. But two, I wanted to get to the end goal, which is graduating from college. That went on until my 3rd year of college, when I had a very severe episode, and I went to the hospital in Raleigh. Now, when that happened, fortunately, the hospital staff in Raleigh were able to recognize that my situation was deteriorating. They actually called my mother and said, we need you to come visit your son because we don't think he's going to make it through this episode. But they did have the foresight to recognize their limitations, and they contacted a hematologist, sickle cell expert at UNC Chapel Hill. They transferred me to Chapel Hill, where I spent weeks in ICU recovering from acute chest syndrome. And it was at that time that I was able to meet Dr. Jean Oringer. Jean Oringer helped to guide my care through the acute chest syndrome episode. I was intubated for about 3 weeks, and he would come and visit me twice a day and talk to me about sickle cell disease. Now, he was also an investigator on the hydroxyurea study, and he would talk to me often about hydroxyurea. Now, I was still a snotty-nosed kid. Hey, I'm talking to him and saying, I don't know if I want to take hydroxyurea. I don't want to be a guinea pig. I've heard of the Tuskegee experiment. Or, hey, what if this gives me cancer? And I'll never forget what Dr. Oringer said to me. He said, Donnell, I can't guarantee you that you won't get cancer if you take hydroxyurea. The studies haven't been done yet. He said, so you can start taking hydroxyurea, and 10, 20 years from now, you could develop cancer from it. But he said, but you just had a severe episode of acute chest syndrome that put you in ICU for 3 weeks. Now, chances are, if you've had one episode of acute chest syndrome, you're more likely to have another. So you could not take hydroxyurea and develop acute chest syndrome in 6 months to a year and die from that. And that helped me to realize that sickle cell is a very severe disease, that there is risk to not treating sickle cell disease, just like there are risks to some of the therapies that exist. So I did start taking hydroxyurea, and that was in January of 1996. Hydroxyurea, for me, was a game changer. It changed my life dramatically. I went from having 3 to 4 crises a year that required hospitalization to not having any crises for years. I was able to complete my education at NC State, being on the dean's list for the last 3 semesters while I was at State. And with the help of Dr. Oringer, I was able to continue down my medical career to go to medical school at East Carolina University. Now, at ECU, I did have just one episode. Hydroxyurea continued to help me. I had one episode that required me to be hospitalized, and I also did have to withdraw to have total hip replacement of both hips due to avascular necrosis in sickle cell. But hydroxyurea, for me, was a game changer. Now, I then graduated from medical school and started my residency in pediatrics in Georgia with the hope of becoming a pediatric hematologist-oncologist. But it was during my residency where I observed not too many patients were taking hydroxyurea. And I just couldn't figure out, hey, we have this wonderful drug. Why aren't patients taking it? And the reasons they weren't taking it, there were some patient barriers. Patients were like me. Hey, I don't want to get cancer. I don't want to be a guinea pig. So they had misunderstandings about hydroxyurea. But there were also barriers within the provider community as well. There weren't too many providers that were prescribing hydroxyurea. At the time, it was limited to hematologists that were willing to prescribe it. And if you weren't seeing a hematologist sickle cell expert, then chances are you didn't have access to hydroxyurea. So I decided at that time that, well, what's the use of developing all these wonderful therapies for sickle cell disease if patients can't get access to them? And what's the use of finding the cure to cancer if nobody can use it? So I decided to go back and get my master's in public health at UNC Chapel Hill. And after completing that, I was fortunate enough to be on the team at HHS.gov that worked on the sickle cell disease treatment guidelines of 2014. Now, the fortunate thing is that care for individuals with sickle cell disease has improved the life expectancy for individuals with sickle cell disease. When I was born in 1971, the life expectancy for a baby with sickle cell disease was 10 years. Most sickle cell patients did not make it to 18, 19, or 20. However, through work and studies at HHS.gov, the National Heart, Lung, and Blood Institute, we were able to find treatments for sickle cell disease. The penicillin prophylaxis study demonstrated that if we caught babies early and treated them with penicillin, we can prevent that overwhelming infection that causes early death. Other studies included the study on transcranial Doppler to diagnose and prevent stroke. And then, of course, the hydroxyurea study, which had a profound impact on my life. But we have to ensure that individuals have access to that therapy. The therapy is only as good as individuals getting access to it. I was then able to go on and work at HRSA, and they're really working on how do we improve access to care. And it became the focus of my life that, yes, we got wonderful therapies, but we have to get them into the hands of the patients that need them. We have to figure out the strategies that extend those sickle cell experts so that we can ensure that every sickle cell patient has access to hydroxyurea, no matter what their zip code is. I know that's a challenging endeavor, but I look forward to working with HHS, with HHS.gov, CDC, and HRSA on continuing to look for strategies to improve access to care. I look forward to working with the National Alliance of Sickle Cell Centers and with the American Society of Hematology to figure out how do we increase the number of providers that at least have that basic knowledge to treat sickle cell disease, and ensuring that every sickle cell patient is able to see a sickle cell expert at least once a year. Preferably more, but at least once a year, they need to see a sickle cell expert to manage their care. And I look forward, most importantly, we're continuing to work with the Sickle Cell Disease Association of America, community-based organizations, to figure out how we improve access to care. Now, I think I'm getting close to time, and my last slide, I wanted to dedicate this to who we're here for today. We're here for the sickle cell warriors, right? Thank you. Unfortunately, we're losing way too many sickle cell warrior years to sickle cell disease. And we have to figure out how to change that narrative. We change that narrative by recognizing that improving access to care, improving access to knowledgeable sickle cell experts is very important. I want to dedicate this, what I'm talking about, to Craigie Sanders, who was a lawyer and a sickle cell warrior who just died, unfortunately, this past July. I want to dedicate this talk to Hertz Nazir, who was an artist that expressed his pain in his paintings about sickle cell disease. And I want to dedicate it to Carlton Hayward, who was a PhD sickle cell warrior, who looked at why aren't we able to get effective care for our sickle cell disease treatment. We have to realize it's not about us. It's about helping the patients and helping the warriors have a longer, more productive life. It's about moving the needle forward 1 inch at a time, making sure that we're getting to where all sickle cell patients can have access to the best care possible, regardless of their zip codes. And that's going to take more than just finding the cure. It's going to involve looking at those social determinants of health, those barriers that prevent sickle cell patients from living the best life possible. I like to think that I've been able to scale crescent moons. I've been able to prevail over sickle cell disease, but I don't feel like I have if individuals with sickle cell disease continue to die early deaths because they're not able to get access to that evidence-based care. So thank you so much for listening to me today. This last part. And now, it is my honor and privilege to introduce our next speaker, a distinguished leader and sickle cell disease champion who has been at the forefront of advocating for health equity and access to care for all Americans. Secretary Javier Becerra serves as the 25th Secretary of the Department of Health and Human Services and is the first Latino to hold the office in the history of the United States. Secretary Becerra deeply cares about sickle cell disease and the warrior community. From day one of this administration, he has been prioritizing sickle cell disease, listens intently to warriors, families, advocates, and healthcare providers, and elevates the warrior voice to inform key policies, programs, and initiatives. Today's summit is a symbol and testament of his commitment to the sickle cell disease community, and we hope this marks a turning point in our nation's support, steadfastness, and urgency towards improving the lives of warriors, families, and communities. The time is now to close the book on sickle cell disease. Please join me in welcoming Secretary Becerra to the stage as the official convener of this inaugural HHS Sickle Cell Disease Summit. Thank you so much, Dr. Becerra. Secretary Becerra. I'll take the doctor.
Thank you. Dr. Ivy, thank you very much. It is great to see so many people here. By the way, I was told that we've got some Californians in the room. Is that true? Oh, my God. Good deal. Yeah. What happened? You didn't bring the weather with you. Well, we're thrilled to have all of you here. We're more importantly thrilled that you would join with us in this effort to, as Dr. Ivy said, really finally make the move to end sickle cell disease here in this country and hopefully throughout the world, because we now know how to do it. We now have the will to do it in this administration, and I know we've got the warriors to get it done. And so I simply want to say thank you for being here to make that possible. To Dr. Ivy and those who have participated with us at HHS for quite some time in our efforts to really try to tackle this. I remember when I became secretary more than 3 years ago, and I got briefed on any number of things. Obviously, COVID was front of mind in everything we did. But I remember getting briefed by our teams at FDA and CDC about where we stood on sickle cell, and how we were approaching the point where we would have therapies that could actually not only relieve the pain, but actually perhaps even change the cells that actually cause the difficult disease that is sickle cell. And that we were on the cusp of seeing something. FDA said it, not yet, but getting close. And I said, so why is it that, and I became a member of Congress knowing a friend who worked on committee with me whose son had sickle cell. And I just remember all the stories whenever we'd get together, and she and my wife became walking partners. She'd always talk about her son and how he was always going through these episodes of pain all through his life. Now, he's an adult, and he is still with us and going strong, finished college, but he's still going through pain. And that is the difficulty is we know if we focus our attention, and because it's a discrete population, we could help. We could really change the lives of people. And so I asked our teams to redouble our efforts, to really encourage the scientific community to do what it can. And then I heard back from the community with lived experience who said, well, yeah, that's great, but what about right now? What about now while we experience the pain? What can we do now? I said, tell me, what can we do? What can HHS do better? I was told some very simple things that were not rocket science. Share data. Make sure that what one community is doing, one provider is doing, if it's working, that others know about it. So that way, hopefully, it'll get covered by insurance and people won't have to go into the ER just riddled and convulsing with pain. What else can we do? Well, make sure that you are including people who have been doing this for a long time and let people know the network that's out there, because some people think they have to suffer through this by themselves. So we have been working harder to try to communicate that information more broadly so people understand that the community that is out there has been around for a long time and you should not suffer by yourself, and know that there are ways to get the help you need. What else? You know that the majority of people who suffer from sickle cell receive their health care from Medicaid? We devote a lot of money, federal government and state governments, to make sure people have access to the health care they need. We could do a far better job of connecting everyone with early preventative care as best possible. So that's what we're doing. But here's the one I want to tell you that does require rocket science that I'm so proud of. When we started to hear from the private sector community that they thought, the scientific community said, they think they may actually have a therapy that could actually relieve the pain and maybe even cure Americans of sickle cell disease, or at least address the trait, that's a game changer. It just happens to cost more than $1 million if you need it. How many people in America who have sickle cell can afford to pay $1 million or more? It's tough. So again, I asked our team, what can we do? And what we came up with was an approach with the authorities that we have, because we can't dictate how much a therapy or medicine will cost. But what we said is this: look, if Medicaid is in the game because we pay for those ER visits, the pain reduction, the organ support, all those things already, how about we use the power of Medicaid to see if we can lower the cost and make that therapy more accessible? So we now have a cell and gene therapy program where we are going to try to do everything we can to get some of these innovative treatments that are coming as a result of all this phenomenal science, and we're going to try to make it available to more and more people, because otherwise you've got to be a millionaire and lucky to have access to some of these treatments, and most folks who have sickle cell are not. So what we're doing is we're creating this new program, and what it does is it simply says, states, join with us. If all of us combine together and tell the manufacturers of these therapies, we will buy your product. We, not the individuals, we, the states and the federal government, will help pay for those products, and with the insurance companies when they have insurance. And we guarantee you business. Because if you try to shop this product to those individuals by yourself, only a handful will be able to afford that product. But if you come to the states and the federal government and you let us buy your product for less than the $1 million, substantially less, we'll buy a lot of your product. And so the power of our collective can give us the ability to guarantee that manufacturer real return on their therapy. Because if they wait for you individually to buy it, very few can say that, raise their hands, I can afford it. But when the states and the federal government come forward, we can buy a whole bunch of it. It's almost like a subscription model. We buy a lot of it, and then we've got the customer base to make sure it gets out there. So that's what we're going to do. with these new innovative therapies and treatments that are coming out for all sorts of illnesses. But here's the good news. The very first test model for this new approach to try to make those medicines available is sickle cell. We chose to use sickle cell as our first model to make sure that we could approach communities that could not otherwise afford it. I mention that because it's not going to happen overnight, and we have to have states buy in. But we finally can say to many people that there might be an opportunity to rid you of that pain, to rid you of the constant fear that you're going to lose your loved one. And so I hope you're here because you want to help us make a difference. I hope you're here because you believe that there is a chance that we can actually change this paradigm when it comes to sickle cell and fearing if you have a child that you might pass on the trait, or seeing your child cringe in pain and not know what you could do. I hope you're here to send a message to the scientific community. Keep going. We're going to figure out how to make your life-saving therapy available to people if you just partner with us and make sure others can afford it. And I hope you will go back to your state governments and say, are you participating in that model? Are you making sure that the people in your state who might have sickle cell have that opportunity to participate? And I hope you will say to President Biden and Vice President Harris, thank you for letting sickle cell be the first test that we use this model on to make sure that a life-saving therapy that just broke the ice can be made available to Americans who otherwise had no hope. That's what this is about. And you are here, I hope, to help us send the message. I see that most of you took off your warrior equipment outside and look pretty formal here, but I know that when you leave this room, you will put that warrior equipment back on and fight to make sure we can get there. I think it is important that we recognize the people who have made this possible. I want to make sure that you know some of the people that have made it possible for you to be here, but for all of us together to take on this fight. Can I make sure that both Sanab Jama, who is with HHS, and Captain David Wong, who's also with HHS, step forward if they're both come. Dr. Wong, Sanab, is Sanab here? Come on, Sanab, come out here. Come on. So you're here. I hope you, for this next day, you're here, you take advantage. But we're here because Sanab and David made it possible. They're the brains, the muscle in getting all of us here together. They did most of the work. Obviously, it was a big team. Our HHS team has been on this. But without their leadership, you and I would not be here today to put on our gear to get out there and be warriors. And I want to make sure that I acknowledge them. And I don't know if anyone from SSA is here. They asked me to go ahead and be their display model for them. For the first time, SSA is actually reaching out to the sickle cell community to let you know what it takes to apply to get SSA benefits for disability. Some of you have probably gone through this process. It is hell. It is hell. It takes forever, right? It is the kind of thing that makes you lose hope. Commissioner Martin O'Malley, former governor of the state of Maryland, who, by the way, has a pretty large population of folks with sickle cell, understands this. I had a conversation with him. He says their team's going to be on this because they recognize that it's taking way too long to get these determinations, and they're going to do everything in their power to try to make sure that people know that they see them. And they gave me this little brochure to make sure I didn't forget to mention that they're on it, because they're working hard as well with the few resources they have to do so many different things they wanted me to mention this, and I am proud to mention it because this is the first time the Social Security Administration has identified any disease for mention and support. And I say that because that's the attitude that this administration has brought to the table on sickle cell. We want this done. We know we can get there. We're going to come up with some tools. But without the warriors, nothing happens. So that's why you are here. I hope you are ready. I thank you for coming. And please know, we are there with you all the way until we finish this fight. Thank you very much for coming. I'm going to turn this back over to Lizzie.
Thank you so much to Secretary Becerra, and we are incredibly excited about that announcement from the SSA, and we'll be hearing from them later today with a surprise guest speaker role, so we're very excited to have them. And now I'm excited to introduce our first panel, and our first panel, you are welcome to start coming onto the stage. This esteemed panel will be discussing the history and evolution of sickle cell disease therapies, including tracking the gradual advancements, come on up, over the decades, and a recent surge of novel treatments, including 2 milestone cell and gene therapies. Moderating this session will be the phenomenal Dr. Kamal Mangrajani, Assistant Director of Cancer Innovation and Public Health at the White House Office of Science and Technology Policy. Joining her will be Dr. Donna White-Stewart, Center for the Drug Evaluation and Research at the Food and Drug Administration. Dr. Courtney Fitzhugh, National Heart, Lung, and Blood Institute at the National Institutes of Health. Dr. Nicole Verdun, Center for Biologics Evaluation and Research, also at the Food and Drug Administration. Mr. Theodore Jimmy Pinnock, warrior and retired nuclear engineer from Suffolk, Virginia, and he refused to give me any nuclear secrets when I asked. Dr. Andrew Campbell, Director, Comprehensive Sickle Cell Disease Program at the Children's National Hospital, which is right here in Washington, D.C. Let's give them a warm hand.
Great. Thank you so much, Lizzie. As she mentioned, I'm Kamal Mangrajani, so I'm actually a medical oncologist and a hematologist, working as an assistant director at the White House Office of Science and Technology Policy. And I just want to start by saying that this summit is so important. We are so excited to see all of you here today coming together to champion the cause of sickle cell disease. I'm thrilled about the conversation that we're going to have, but also about the conversations that you all will continue to have and the work that will come out of all of our discussions today. Thank you so much to David, to Zainab, and the organizers for putting this together today and for inviting the White House Office of Science and Technology to take part. As a hematologist, a lot of what Dr. Ivy was saying really resonated with me. I've had people reach out to me saying, I've had pain crises, I'm not sure what to do. It's hard for me to find a hematologist who knows sickle cell disease. I've never heard of hydroxyurea before. Is that something I should be on? I've taken care of patients in the ICU, and Dr. Ivy told his story so amazingly and so beautifully, but I've seen patients for whom hydroxyurea failed them. And they were in the ICU with recurrent acute chest syndrome. And this was many years ago, but back then there were really very few other treatments, if any, to offer them at all. But a lot has changed, and there's a lot of reason for hope. There are new therapies that have come online and become available, and that's what we want to focus our discussion on today. So to start, I want to turn over to Dr. Donna White-Stewart. If you would please introduce yourself and tell us a little bit about the history of sickle cell disease and where we are with treatments today.
Great. Thank you, Kamal. Good morning, everyone. It's a pleasure to be here. It's not often you get to be a part of something inaugural. So my name is Dr. Donna White-Stewart. I'm a physician or medical officer in the Division of Non-Malignant Hematology at the U.S. Food and Drug Administration. So like Kamal said, I'll provide a very brief overview of sickle cell disease and then talk about the development of therapy for the disease. So sickle cell is one of the most common inherited blood disorders, which affects over 100,000 people in the US and millions worldwide. It is an inherited disorder caused by a single change or mutation in the beta globin gene, leading to the formation of sickle hemoglobin. This one change causes the polymerization of deoxygenated sickle hemoglobin and the resultant sickling of red blood cells. Deoxygenation of the red blood cell causes the cell to form a sickle shape. This cell is adhesive and fragile, and it causes blockage in the blood vessels and the destruction of the cell. The clinical manifestations of the disease include, as you all know, pain crises, infection, pulmonary complications such as acute chest syndrome, neurocognitive dysfunctions such as strokes, retinopathy, kidney disease, and priapism. Due to these long-term complications, the disease is associated with increased morbidity and a decreased life expectancy. Sickle cell disease was initially described in literature in 1910 by Dr. James Herrick. The first federal funding for the disease was in 1972 under the National Sickle Cell Anemia Control Act. In the absence of disease-modifying therapies, providers focus on screening and prevention. Simple exchange and chronic transfusions are used. Eventually became the development of drugs, transplant, and gene therapy. I'll focus on drug development and gene therapy, and transplant will be discussed later by my colleagues. The FDA is a data-driven agency. When it receives data, the agency can act on that data. However, the collection of data can be a problem if research funding is delayed. The development of therapies for sickle cell disease moves slowly, much slower than for other diseases in which there are far fewer patients affected in the US, such as cystic fibrosis, amyotrophic lateral sclerosis, and hemophilia. The discrepancy in funding was a topic of an article published in 2020 by Farouk Moghazil, Lanscron, Haywood, and Strauss. The authors state that in the US, though there are approximately 90,000 individuals with sickle cell and approximately 30,000 individuals with cystic fibrosis, however, from 2008 to 2018, federal funding was greater per person for patients with cystic fibrosis at approximately $2,800, compared to sickle cell at approximately $800. The genetic variant leading to a cellular membrane protein malfunction in cystic fibrosis was not identified until 1989, and the approval of the first targeted therapy to correct the underlying chloride transport variant was in 2011. The article notes that the role of race and ethnicity in the context of healthcare disparities in the US is well documented. The article also states that disparities in funding between sickle cell and cystic fibrosis may be associated with decreased research productivity and therefore decreased novel drug development for sickle cell disease. In the early 1990s, the National Heart, Lung, and Blood Institute, or NHLBI, funded a large randomized double-blind placebo-controlled trial to understand the effects of hydroxyurea on sickle cell disease. Hydroxyurea, as you've heard about earlier, causes an increase in fetal hemoglobin production, which inhibits the sickling of the red blood cell. The groundbreaking results from the study enabled the FDA to approve hydroxyurea for the treatment of sickle cell disease. Almost 20 years after that approval, in 1998, L-glutamine, or Endari, was approved for the treatment of sickle cell in 2017. This drug causes sickle cells to be less adhesive or sticky. The drug demonstrated a decrease in vaso-occlusive crises, or pain crises, and had a favorable safety profile. In 2019, crizanlizumab, or Advaco, was approved. This drug blocks a protein called P-selectin, which makes cells less adhesive or sticky. The drug was approved based on the decrease in the rate of pain crises. In the same year, voxelotor Oxbryta received accelerated approval with a post-marketing requirement to provide evidence of clinical benefit. This drug binds to sickle hemoglobin and decreases the destruction of red blood cells. Accelerated approval was based on a study that demonstrated the effect of voxelotor on an endpoint that was reasonably likely to predict clinical benefit, an increase in hemoglobin. The company has chosen to demonstrate that an improvement in hemoglobin due to voxelotor is associated with a reduction in cerebral blood flow velocity as assessed by transcranial Doppler, or TCD. A major clinical benefit in the treatment of sickle cell disease would be to demonstrate a decrease in the risk of strokes for patients with sickle cell disease. While there are finally more available therapies for patients with sickle cell, many patients continue to experience the complications of the disease. There remains a great unmet need for new, effective, and safe therapies for sickle cell. the future of drug development for sickle cell is encouraging. In the pipeline are drugs that focus on different aspects of the pathophysiology of the disease. These aspects include increasing fetal hemoglobin, like hydroxyurea, inhibiting hemoglobin polymerization, decreasing adhesion, targeting inflammatory and oxidation pathways, and targeting vasculature. In 2018, the FDA and the American Society of Hematologists, or ASH, held an endpoints workshop to develop consensus recommendations for clinical trial endpoints. The FDA also holds patient listening sessions to obtain patients' perspectives to then inform the development of endpoints and products. At the most recent session in May of 2023, the participants mentioned concerns such as the impact of therapies on fertility and childbearing. These patient perspectives are very important to the FDA, and we need that feedback as we contribute to the development of endpoints and products that will make a significant impact on the disease. We would also like to further understand the barriers to participation in clinical trials so that we can move the development of therapeutic agents forward. The FDA has a number of ways to advance the scientific knowledge of sickle cell and promote the development of new therapies for the disease by providing grant resources via the Orphan Product Grant Project, Rare Pediatric Disease Designation, and Priority Review Voucher programs, as well as through the Centers of Excellence in Regulatory Science and Innovation, or CIRSI. The agency looks forward to working with the stakeholders to explore novel endpoints, biomarker development, and innovative trial designs for the development of future drugs to treat sickle cell disease. Thanks for your attention.
That was wonderful. Thank you so much, Dr. White-Stewart. Tracking those 4 different therapies, hydroxyurea, L-glutamine, crizanlizumab, voxelotor, there are clearly many more options now than there were back in 2016. But as you mentioned, there's still much more to be done. I'd really love to go to Dr. Courtney Fitzhugh next, if you would. Tell us a little bit about stem cell therapies and your experience with sickle cell disease.
Good morning. Thank you so much for inviting me to speak on behalf of the National Heart, Lung, and Blood Institute at NIH. And I'm going to speak about the work that's done in my lab and also the lab of Dr. John Tisdale. And I'm going to focus on the type of transplant where there's a separate person who serves as a donor, typically a family member. So we know that sickle cell disease impacts red blood cells. And red blood cells and other blood cells that we make are made by blood stem cells. So the goal of the type of transplant that we do at the NIH is to take the blood stem cells from a family member, give them to the patient. Ideally, they'll grow, make normal red blood cells, and cure the patient. Traditionally, the type of transplant that was offered in the mid-90s was only to children who had siblings who were a complete tissue match. And what we worry about most with these 2 types of transplants is, one, the patient can actually recognize the donor cells as being foreign, just like if they were bacteria, and attack them. That's called graft rejection. We actually worry more about something called graft versus host disease, where the donor immune cells can recognize the patient as being foreign and attack the patient. And that can cause hardening of the skin and scarring of the lungs and can be deadly. We don't want to replace something that's even worse than sickle cell. So, like I said, what was traditionally done was to take the blood stem cells from a sibling who's a complete tissue match, give the patient high-dose chemotherapy, completely wipe out the bone marrow, replace it with that of the donor. And this approach was really effective. It's actually 95% effective now in children with sickle cell disease. And there's about a 10 to 15% chance of graft versus host disease. So when I first went to the NIH and worked with John Tisdale as a medical student, we knew that many adults with sickle cell disease have overt organ damage and aren't able to tolerate high-dose chemotherapy. So we wanted to develop a different type of approach. And instead of completely wiping out the patient's bone marrow and replacing with that of the donor stem cells, we realized that you can create a state of what's called mixed chimerism, where there's a mixture of donor and recipient cells. And with this, if it's successful, there's a lower risk for graft versus host disease. So we started I did a mouse transplant project and gave these mice medicine to help them suppress the immune system, and actually it was successful. I gave the mouse the medicine for a month, 8 months later, the mice still had a mixture of donor and recipient cells. So it's really exciting that this led to the transplant program that we now have at the NIH. So we started in adults who had siblings who were a complete tissue match. And it worked in 85% of the patients, and we didn't see any graft versus host disease. So we have a new protocol that's ongoing now where we've added more medication to try to improve those results and have a less chance of graft rejection. But the problem with this approach is that less than 15% of patients with sickle cell disease have a sibling who's a complete tissue match. So what my lab works on is haploidentical or half-match donor transplant, because 90% of patients with sickle cell disease have a parent, a child, or a half-match sibling who can serve as a donor. And because the tissues are now half-match, there's a higher risk for graft rejection, and there's a higher risk for graft versus host disease. So we started in our first protocol in 2009, and we wanted to, because at the time, only the NIH and Hopkins were transplanting adults with sickle cell disease using a haploidentical approach, and we didn't know what the efficacy or the toxicity would be. So I enrolled patients who were really sick, patients with on dialysis, patients with cirrhosis and heart failure, and pulmonary hypertension, and I thought we're not going to have a long life without giving them a chance at a cure. And it worked in half of the patients. So we weren't happy with that. We opened up a new protocol in 2017 where we added more drugs to suppress the immune system. And we fixed the graft rejection problem, but caused new complications with viral complications. So we closed that protocol and now have a new one where we're giving a moderate amount of immunosuppression. We think the first protocol didn't have enough, and the second protocol had too much. So we're very excited about this new approach, and we're really trying to target patients that are not offered transplant on the outside, either because of severe organ damage or because they don't have insurance. That's one thing that's really beneficial about the NIH. If you have, as long as you're eligible for the protocol, you have access to this. So we still have a long ways to go. We're also really interested in studying, we don't want to just reverse or cure sickle cell disease. We really want to prolong lifespan. We want to improve quality of life. We want to take pain away. So we really want to study what the long-term health effects of curative therapy are in patients with sickle cell disease. And I'm involved with a multi-center study where investigator Vanderbilt is leading it, where we're enrolling hundreds of patients with sickle cell disease, where we can really see what's happening, not only with curing them, but really seeing how we're impacting them lifelong. So thank you again. I'm really happy that I was able to be here.
Thanks so much, Dr. Fitzhugh. It sounds like at NIH you're really trying to break down barriers, trying to make sure that people who wouldn't otherwise have access to a treatment that could cure them of their sickle cell disease can have access. And as you mentioned, the NIH is a wonderful place where a lot of these expenses can be covered. So for people where a financial barrier may be in place, the NIH can help solve that problem. Also really wonderful to hear your work on graft failure for people who go through a stem cell transplant, for them to go through that whole process, that whole ordeal, which is thought of like a surgery, and then at the end of the day for it not to work would be incredibly disappointing. So I'm excited to hear that your lab is working to try to prevent that from happening, and also to try to prevent the new cells that are taking hold from floating around and attacking the person's body. So I think these are all huge breakthroughs for the sickle cell community, and I'm really excited to hear about that work. Now we'll go on to Dr. Nicole Verdun from the FDA, and if you'd like to tell us about 2 new potentially curative therapies that were recently approved.
So thank you so much for having me and for being in, this is just an exciting time in sickle cell disease. So my name is Nicole Verdun. I'm actually a pediatric hematologist by training, and this is sort of full circle for me. Drew and Courtney, or Dr. Campbell and Dr. Fitzhugh, and I have been, partners in this for almost 20 years. I don't want to date us, but this is just exciting to be on a panel with where we're talking about multiple options for sickle cell disease. I mean, that's just huge. And it really is not lost on me. So I'm a super office director at FDA. So what that means is I manage 6 offices that have to do with the regulation of cell and gene therapy for the United States. And so it was really my pleasure. So that's in the Biologics, Center for Biologics. Dr. Donna White-Stewart is in drugs. So they're different centers. And it was really my pleasure to have approved 2 gene therapies for sickle cell disease. I mean, that was just an exciting time, and it continues to be an exciting time. So we have 2 therapies approved. One is Casgevy, and the other is Lyfgenia. And both of these use different technologies that are quite novel. So Casgevy uses a technology, a genome editing technology, called CRISPR. In CRISPR-Cas9, you're able to do some ex vivo modification of stem cells. So take them out of the patient and to modify them and then put them back in and have that patient then make those stem cells which will modulate sickle cell disease. And so Casgevy uses a unique technology called CRISPR, and Lyfgenia uses a technology that is a gene addition technology. So it's different technologies, but both are doing ex vivo modification of stem cells and replacing those stem cells. And then that patient is able to make a hemoglobin that is either quite like an adult hemoglobin, so a hemoglobin A type, or the upregulation of fetal hemoglobin, which, as many of you know, is something that will hopefully prevent sickling. And so what we have seen with both of these therapies, they've been life-changing for the patients that receive them. A couple of things that I just want to highlight at FDA that I am very committed to is making sure that we get therapies to patients quicker as we see these types of sweeping effects. What that does mean, though, is a partnership, a continued partnership with FDA, with clinicians, with academicians, as we are continuing to gather data, long-term data, long-term follow-up. But the importance really is that we have to be able to get therapies to patients. The other piece that we really have to figure out is access. And that is something that, unfortunately, at FDA, we partner in trying to figure out ways that we can impact that. But in terms of the cost of therapies and access, it really is a partnership between all of us to figure out how we can get there. I can get those therapies approved, and I can make sure that they're safe and effective. And then the partnership comes with patients and families to continue to give us information. This is continuing to work for us. This is how I felt or didn't feel, side effects, other things. And we have partnerships with a lot of the companies that are developing these novel technologies to ensure that we're continuing to get that information. But it is really my joy, my commitment, and it's really been a wonderful and exciting time these past few years to have therapies that are almost preventive in nature and not that we're treating symptoms. We really for a long time wanted to get away from therapies where we're just treating the pain after you have already developed the pain. It's so exciting to be able to give something to someone and say, you might never actually have pain. And it's just a shift. And we have a lot of things in the pipeline that are continuing. It's an exciting time, and I am here to partner with all of you, and I'm really happy to be here. So thanks for having me.
That's awesome. It's wonderful to hear the FDA, really focuses on safety and efficacy, but it sounds like you really recognize the urgency of the situation. These treatments can be life-changing for people. They can prevent them from having the pain in the first place. So in addition to making sure that they're safe, making sure that they work, it sounds like the FDA is also focused on speed. How do we get this to people quickly? How do we give them access to it? And of course, the FDA, they're not the ones who are actually manufacturing these products or implementing them in a clinic, but through those partnerships can hopefully make it so that more people can have access to these treatments faster. Really excited to hear about that work.
Thank you.
And so next, I'd really love to hear from Jimmy Pennock, who is a warrior himself. So Jimmy, if you would, please introduce yourself and tell us about your personal experience and your experience with the different treatments we've been talking about.
Hello, everybody, and thank you for coming today. My name is Jimmy Pennock, and I have HBSC disease. I'd first like to acknowledge the VCU Sickle Cell Program and Dr. Wally Smith for giving me the opportunity to share my voice today with you. And I also like to acknowledge and met Donnell Ivy with the Sickle Cell Disease Association for giving me the opportunity today, again, to share my experiences. Like I said, I was born with SC disease back in 1960. It wasn't diagnosed until I was about 6 years old. As you know, they didn't know very much about it back then, but we all present differently. So with me, I had pain crisis as an infant, through adolescence, all the way through college. And actually, my last crisis was at 57 that I'll talk about later on. But also, you know, I was able to graduate from high school, graduate in engineering from college, because I had doctors back then, fortunately, that didn't know much about sickle cell, being from Tuskegee, but they did work with you. They did the best that they could do. So I was able to graduate from college. I had to withdraw one semester from a bad crisis, but I was able to finish. So I managed to get my degree. As far as once I started working in the shipyard and the crisis continued all the way through, you know, into my late 50s and 60s, I had primary care physicians, but back then they did not know, or they did not refer me to a hematologist or sickle cell programs. So it wasn't until I started experiencing complications like avascular necrosis, retinopathy of the eyes, lost my gallbladder, and it was my eye doctor that says that, hey, you don't have you don't have diabetes. I'm not sure why you have it, but you need to talk to your doctor about it. And it's when I found the EVMS sickle cell program that I found that all of this was related to my sickle cell disease, all of these organ damages. I knew about the crisis. So shortly after finding them, unfortunately, they lost funding and they lost their program. And in about 2020 is when I found the VCU sickle cell program. So I actually traveled about an hour and a half every 4 months to go to the VCU program in Richmond, Virginia. And it's there where I found out about hydroxyurea and Endari. So why hydroxyurea and Endari for me? Well, on my last visit, I found out for the first time since me knowing about bilirubin is kind of like a byproduct of your cells dying, your sickle cells, is that it actually dropped to within normal range. Never seen that before in my life. My hemoglobin F actually increased. So in my crisis, like I said, I haven't had a crisis until 57, but it slows the progression of the damage that I've experienced thus far. So for me, you know, that's why I do the hydroxyurea and Endari, which the Endari increases your L-glutamine, which reduces the oxidative stress. So yeah, those are some of the reasons. As far as I like to advocate for programs that, like Dr. Campbell and Dr. Wiley Smith head up, it's there where I learned about my therapeutics. It's also there that I learned about patient navigators and community health workers that connect you to services outside of the VCU program. Just on this last visit, about a month ago, I signed up to this pilot program between the Sickle Cell Disease Association and MedicAlert. That they for those that have sickle cell disease, they give you these MedicAlert QR code cards that are free. So I asked the clinic, hey, can you help me develop a pain management plan? Because in the event that I'm away from the clinic and I need help, I've run into dozens of times where you have ER doctors that have never treated sickle cell, know very little about it, or suspect that you're in a crisis because, you know, you're not rolling all over the floor, I guess, in pain because you try to manage it by staying as calm as possible. So they actually have support or NPs that assist in writing your sickle cell disease programs, in addition to pharmacists that will help you through, you know, what the benefits are of drugs like Endari and hydroxyurea. So in closing, I also think for me there is an impact. So I'm fortunate enough to work at the shipyard and have health insurance, but with a 10% copay when I was going to the emergency room, going to hospital stays once or twice a year, my copays would be from $1,000 to $3,000 a year, easily. But since I've been on the hydroxyurea and Endari, $100 per visit 4 times a year, for the doctor, and no ER visits, no hospital. So $600 a year for, that, and then that's their part. My part is, maybe $60. And then as far as your medication, I pay $100 a year out of pocket. So it has, to me, a huge public health, a huge productive capacity, as far as quality of life on us. So, those are my experiences that I wanted to share with you in growing up with sickle cell disease. And I thank you very much.
Thank you so much, Jimmy. I'm so glad to hear that these treatments were effective for you. It sounds like it was life-changing.
It really is. It really is. Even when I have a crisis, I think I had one about a month ago, it feels like a bad ache, and rarely do I take anything. And that's the other thing. If I have to take anything, I don't keep pain medication. They have 24/7 service at the VCU program that if I call today or page today, they can prescribe a pain medication if I didn't want to go to the hospital and try to treat it at home. So yeah, it's really been life-changing.
That's really fantastic. I think this is sort of the goal of the work that we're talking about up here, is how can we get people to a place where they're just able to live their life. They're not going back and forth to the ED. They're not in pain.
Correct.
They're just, out there living their normal, healthy life. And so I'm really glad to see that worked out so well for you.
Yep. Thank you very much.
And as you mentioned, having that support, being able to see a hematologist, being able to have that connection to the healthcare system, to have that guidance is so critical. So I want to turn it over to Dr. Drew Campbell. If you would introduce yourself and tell us a little bit about your perspective as a physician who cares for patients with sickle cell disease.
Thank you so much. I want to thank HHS and the organizers for inviting me to speak. First thing I would just like to say, I want to give a shout out to our Children's National people who are here and our warriors who are here and all of our advocates. I think it takes a village to take care of our sickle cell patients. So I came from the University of Michigan, where we had a small population, Kimberly Davis, who's in the audience, helped found it, and she showed me, what were the health disparities, even within the hospital, as we cared for sickle cell patients at the University of Michigan. But when I came to Children's National, we have 1,500 to 1,600 patients in our program. So the first thing I would like to say, it takes a village. And we have 5 or 6 nurse coordinators, 6 hematology providers, that's physicians and NPs, psychologists, which are here in the audience, and also we have social workers, who I think is the cornerstone for our program. And we still struggle with all of that help. And what I would say is that, number one, we need to believe our warriors, and we have to trust our warriors. When our warriors say they're in pain, they're in pain. I would say that in our program, we see the different disease we call phenotypes. So I'm so glad to hear about the hydroxyurea working for so many of our warriors, as Jimmy and Donnell Ivy. But I will tell you, in our population, we see that 10 to 20% of patients, hydroxyurea does not work. So those are the populations that they have high fetal hemoglobins, but they still have pain daily. They have avascular necrosis, and these are pediatric patients. So we welcome some transformative and curative therapies for those patients because they are struggling, missing school days, parents missing work. So there's that population that needs other therapies. So bridges me to newer therapies. We need other disease-modifying therapies. We're excited that we have at least 4 new ones since 2010, but it took 100 years to get to the first one, almost 100 years to the first one. So we really need to promote disease-modifying therapies, clinical trials for new therapies. The curative therapies, not always, and transformative therapies is not going to always be the answer for our patients. So I would like to push that because we need more research at the NIH, pharma, everyone to do more research for our warriors who are not responding to these the current therapies that we have. The second point is access. I just want to mention that, we can only do so much as providers. We struggle of going through their prior authorizations, even if it's from curative therapies, transformative therapies, but just even like, for example, Oxbryta or even hydroxyurea. We need to get recently a prior authorization for hydroxyurea for a patient. And we don't have, we just don't have the bandwidth sometimes to try to do that. So we appreciate all of our warriors or advocacies such as Sickle Cell Association of America, or, for example, Sickle Cells with Ashley Valentine, anyone who can help bridge that gap in terms of talking to our congressional representatives, government representative, HHS, to bridge the gap so we can get these therapies. So we can have all the therapies in the world, but if we don't have access to them, we're going to struggle. And we are already seeing that right now. The last point I want to say is that with the new transformative therapies that's out there, and we are going through it right now at Children's National. We're very excited about it. I would say that we still need additional therapies. So not everybody's a match for bone marrow transplant. And haplo is great, and that is great for a lot of our warriors as a viable option for our warriors. But I think if we could increase the technology in approving therapies that patients can utilize as a treatment option. I think it's a different perspective coming from a lot of our parents who sometimes see their child going through sickle cell disease and pain day in, day out, and they envision sometimes their child as an adult who may struggle as an adult, who may not respond to hydroxyurea. So this is an opportunity for them to have science help them in the future. And we also know, lastly, is that before going into the curative therapies, for example, there is also organ damage that happens prior to that. So we also have to educate our families that sometimes even after the curative or transformative therapies, pain can still be there. That's something that we have to be transparent about as well. And I think we need to be a proponent of that, is prior to transplant and after transplant, that we have to be transparent about. Sometimes after transplant, you may have pain. But overall, I'm very excited about the trajectory of sickle cell disease and their therapies over the past 100+ years. I just hope that we continue to have more forums like this so we can all come together, because it really takes a village. Thank you.
Absolutely. So just your point on prior authorizations, this is reaching out to the insurance company, making sure that they're going to cover a treatment before that treatment can actually be given. And CMS is actually telling these companies that if they get a request and it's urgent, they have to return information and say yes or no within 72 hours. If it's not urgent, they get a week. They're also trying to get them to do it all online so that this can be done much more quickly and easy, no more using fax machines. It's 2024, it's time to move forward. And also collecting information so that we understand if an insurance company is not saying yes, why is that? Is there a chance for somebody to appeal? Is there a chance for us to collect information about when insurance companies are saying no, so that we can better understand, okay, how do we change our strategies here? Is that really appropriate? So, just to highlight, we're here at HHS. This is something that the administration is thinking about and trying to make moves towards, and hopefully this will be a first step as we think about how we can work with insurance companies to get prior authorization to be a much easier process. As I think about the treatments that we've been talking about today, I'm really struck by, how advanced the science has become. 100 years ago, if somebody said, oh yeah, one day for sickle cell disease, we're going to take somebody's stem cells out of their body and put them into the body of a warrior, and those stem cells are going to help cure that disease. Or what if we said, for a warrior, we're going to take your own cells out of your body, we're going to use, a system that we discovered in plants, and we're going to change your cells a little bit, give them back to you, and that should prevent you from having acute pain crises. It just seemed, 100 years ago that would have been science fiction, but today that's the reality that we really have. And the way that we've been able to come so far is through the research. And so what I'd really love to open up to our panel now is talking a little bit about the importance of this research, how warriors can engage, and your thoughts about helping more people who might be interested in studies connect with the research ecosystem.
Yeah, so we really depend on the warriors to be able to move the field forward and to develop these cures and transformative therapies. And I see some of the warriors in the audience that have actually come to the NIH and enroll in our trials. We can't do it without you. We do a lot of first-in-human studies. It takes a lot of courage, a lot of boldness to come to us and trust us. We spend a lot of time, a lot of the trust that has been broken with our patients and providers. We spend a long time really trying to establish that trust. So we become very close to our patients and we go through it with them. So I'm just very grateful. We can't do it without you, so thank you so much. And I would say one way to learn about trials, not even just curative therapy trials, but drug trials, is to go to sicklecell.nhlbi.nih.gov. They have a lot of resources on that website to learn about what's going on. And there's just so much exciting work. So if you just need to develop hope and excitement about what's going on, that's a good place to go. So sicklecell.nhlbi.nih.gov.
And I guess, Jimmy, I want to know from you, have you ever, do you know anybody who's ever been involved in research? Is that something that you would ever consider as a warrior yourself?
So, yes, I actually have registered for the program, and I also attend a VCU support group for men of other sickle cell warriors. And I had one gentleman who's in his 20s and asked me, hey, would you get the gene therapy? And, I told him, I can't speak for you, but going through the complications that I've gone through, and I continue to go through the complications, and he experienced this crisis, I told him, yes, I would sign up for the gene therapy as a SC warrior, and he has SS. So, yes, that's one way. I think we can spread the word, is that we participate in these VCU support groups. And then through the actual special programs where they also put out information on the various therapies.
Yeah, I would just like to add that Sickle Cell 101, Sandra, she has Trimble. She's done it. I think that's a great job. Sickle Cell 101 is a great site. SCDA. Also, just talking to other warriors. I think having other warriors who've gone through clinical trials, I think that's their best advocates. Having forums on sickle cell gene therapy or curative therapies or any clinical trial studies. If warriors talk to each other, I think, and also having forums where you might have organizations, might have a forum where a guest might talk about their experience outside of healthcare providers, outside of the medical space. I think that's also very effective, having that as well.
And I would just like to add, representation matters. So when we have clinical trials ongoing, it's very important from the standpoint of, does this work? How does it affect patients, to have a representative population of people that are enrolled in trials that have, different effects from their sickle cell disease or different ways in which each of these therapies may affect them. And so it's extremely important to be engaged in that process. And I don't take trust lightly, as Dr. Fitzhugh said. This is a partnership here. But the more that we're able to gather information in the right way in a clinical trial setting, the better we are.
And I really applaud you all for your efforts to make research an open, inviting process that's very transparent. I know a lot of the work that you all have done in terms of being clear with people who come into the clinic, explaining the research program, answering questions, just to make sure that people have an understanding and feel comfortable engaging with that research process. All the progress that we've seen in terms of the development of these new treatments wouldn't be possible unless people volunteered and said, yes, I want to help advance the field. Yes, I want to be a part of the research. Yes, I want to help us get to more treatments and more cures faster. So again, there's a really vital role that people with sickle cell, their families, and their caregivers play in engaging with the research process so that we can accelerate research and development for people with sickle cell disease. I think we have maybe just a minute, so I will ask one more lightning round question. But only about 30 to 40% of sickle cell patients who are eligible for hydroxyurea or other treatments are actually getting them. So how do we get the word out? How do we encourage more people to seek appropriate treatment? How do we increase the number of people who are getting these therapies?
One thing I'd like to say real quick is, as I mentioned, I have PCPs that I go to every year, but they're not, and I didn't know. You don't know what you don't know. So I didn't know that I should be looking for a hematologist, but the advice they gave me was not enough, and it was until I had the complications that I sought it. But how do you get PCPs to direct you to a hematologist or to direct you to a sickle cell program if they have you as a patient? Because as a patient, you trust them. And so I just didn't know what I didn't know until I was in my mid-50s.
I think education and awareness is extremely important. I heard some Dr. Ivy and others mention hydroxyurea and the concern for cancer. Hydroxyurea was FDA approved in 1998, so we have now decades of research that's been done since hydroxyurea has been FDA approved. There has been no link to hydroxyurea and leukemia development or any type of cancer development. Study after study, infants, children, adults have shown just how much it decreases pain crises, increases decreases the need for transfusions, and even when dosed properly, it can improve survival. So it's just really getting it out, not even just to the patients, but to the providers. Making doctors comfortable to prescribe hydroxyurea, I think, will help make a difference.
Countering the misinformation that's online, and also just the providers. I think at the sickle cell comprehensive centers probably have a higher use, but it's the centers where there's not a lot of sickle cell experts or trainees who are providing sickle cell care, so kind of the hub and spoke. So those are in the rural areas. Those are the areas where a lot of our sickle cell warriors are cared for, but they may not be telling them about hydroxyurea as an effective therapy.
And just one more quick point. Just speaking about information online, social media, everyone has access to it. Mm-hmm. So I think as much as other people are using it, the people with the facts and the data should also be accessing it and putting information online, because people are going to see it there as well.
Hashtag HHS Sickle Cell Disease Summit. Nicole.
I agree with everything that everyone said. I think we need to get more innovative with our communication. We need to think out of the box. And there is also a piece of this where we need to educate other providers as well, and do our job. All of us here on the stage have a different, I'd say, a different understanding and appreciation for what a warrior goes through. But not every provider that people encounter has that same appreciation. So coming up with innovative ways to continue to get our message out there and get, the respect that we think the warriors deserve and need.
Absolutely. And with that, we'll conclude our panel. I just want to say thank you so much to all of you for raising awareness, for treating these patients, for working on developing new cures, and for getting them to patients as quickly as possible. Really just phenomenal, all the work that you all are doing. Thank you so much. And thank you, all of you, for being here today.
Wow, that was a remarkable panel. And I'm struck here by the title of that panel, which is Gradually Then Suddenly. And Dr. Campbell expressed just now the importance of a village in the care for individuals with sickle cell disease, their families, their loved ones. We're a village right here. We have a lot of people in this room with a lot of power and a lot of access. And so I wonder if you're willing to indulge me, if you can take a moment and think, what role can you play in accelerating progress for either the individuals in your life or this movement overall? And I used to teach, so of course I'm going to encourage you to write it down because it's good for memory. But I think this is a great opportunity to think about how we together can take the next step. Before we move on to our next panel, I just want to do a friendly reminder for any warriors in the room. We do have blankets, warm blankets up front at the registration desk, water, anything you need, please just make your way up there and one of my colleagues will help you with your service.
Produced by the U.S. Department of Health and Human Services.